Morning, everyone. I'm Elizabeth Bryce. I'm the Executive Director at Leisureworld Caregiving Center St. George. Has anyone heard of Leisureworld St. George? Oh, wow. That's good. Okay. So what I'm going to do is I'm going to let you know the history of Leisureworld St. George. And then after that, I'm going to let you know of the improvements that have happened from 2006 to 2012. I've been the executive director there for 1 year, but I was there for 8 years as Candace stated, activation aide, and then program manager, and now this role. So I'm going to give you that analysis from that time to what I've been experiencing the 1 year last year. Okay. So I'll give you a little history of St. George. Again, like our colleague Dot has mentioned, we too are a C building. We were built in 1973. We have 238 licensed beds. We have 5 home areas, and we have a specific clientele in each of our home areas. Our first floor, which is Orchid Avenue, actually has a clientele that are palliative and also to need a lot of medical and nursing care. Our second floor has a clientele of residents with cognitive impairment, dementia, and a lot of associated behaviors due to dementia is on our second floor. Third is also our behavioral unit, where we have many of our residents with diagnoses, and I will give you a history of that and the numbers and our demographics with that. But we do in our third home area have residents with many mental disorders and disabilities such as schizophrenia, bipolar, depression, personality disorder, and so forth. Our fourth and fifth, we have a mix. We have our higher functioning residents and we have our lower functioning residents. So this is an interesting mix in our fourth and fifth. Many of our residents go out in the community. They sometimes just come into the home and have their lunch and dinner and breakfast, and then they go out in the community and they do the things that they like to do. We also too have a supervised smoking area. We have a large population of smokers in our home. We have 92 out of 238. So prior to 2006, I'm going to let you know why we have this large population of residents with behaviors. Prior to 2006, we had a different clientele. We had our traditional long-term care home population. Unfortunately, they passed away, and many of that also too, our residents moved to retirement residencies. So because of that, our occupancy level decreased. And what was out in the community at that time were a lot of difficult, unmanageable behaviors, and other long-term cares didn't want to receive. So St. George had to fill in those empty beds because occupancy is very important. And due to that, we had to accept these residents, or residents with many psychotic, psychiatric disorders and disabilities. And it just became a trend. And it went beyond that, and now, right now, we have a large population of this now. So the type of clientele that we accepted were residents that were unmanageable, residents in community agencies that were difficult, and so forth. Thank you. So again, too, as I mentioned before, the residents that we accepted were a lot of residents with bipolar, schizophrenia, dementia due to alcoholism, clients with a lot of social issues, homelessness, sexual, physical, abusive histories, alcoholism, drug abuse, and past criminal activity. So MOH at that time visited us weekly to see if we could manage, and it was a lot of stress on the home, and a lot of difficulties in bringing in a new structure. So improvement plans within the 2006 and 2012 is we increase our partnerships with COPA and CAMH and our psychiatric outreach team from UHN to assist in the transition. We do a lot of interprofessional meetings, which takes a lot of the time of the staff, but it was essential in knowing the type of clientele that is coming in. Pre-admission is very important, knowing initially what the resident is before coming into the home, understanding the history, understanding all of those important incentives. Also, too, many of the clients lived in a world of no authority and direction. So that's very difficult in long-term care. As you know, we are highly regulated. and we have a number of policies that we have to adhere to. So it was very difficult for that, and especially for residents like this who were homeless, never had really rules or anything like that to come in, was very difficult. So that was a challenge also. So in our home, many of our residents have many hats. For me as an executive director, it's not just the paperwork, the office work, but it's the social aspect. It's me going on the floors, talking to the residents, doing one-to-ones, very important. I do this daily. Education of staffing was essential, and at St. George, they have done many. We're very lucky to have Preferred Health in our Leisureworld organization, which has assisted us in a lot of our education, and as Dot mentioned, such as GPA, I would say pieces, You First, Montessori, you name it, we've done it. We've increased residents' choice, preference, and made residents feel at home. Very essential. We too have to, know that they are people that lived in the community. They had a life, so we have to bring the life into our home, and that's not easy for some of our admissions. When we do our tours, we're bringing in people to showcase the home, and they see this. Not easy, because they see long-term care. They see our home as something as not long-term care. And it is very difficult to fill in our beds of clientele that are coming out of retirement, coming out from other long-term care homes in our catchment area. So, oh, there you go, okay. So I'll give you a bit of the demographics. Our average age, very young population, female 69, male 66. Females have decreased. We had an increase. Now we have a decrease of females. The majority are males, 58%. Number of residents with diagnosed, 78 schizophrenia, 72 dementia, 46 with depression, and 21 bipolar. Number of our residents with mental health disorders due to substance is 18. 38 of them have issues of addictions, and as I said before, 92 are smokers. Our staff ratio is approximately 1 to 48 for nurses, 1 to 48 registered practical nurses, 1 to 10 to 12 for personal support workers. Okay, I give a little bit of our situation analysis. I'll give you the statistics. 2013, we had 30 critical incidences of aggressive behaviors. Majority were resident-to-resident abuse. In 2013, we had 100 calls to the police. This is much of a challenge for our police force. I know I've received countless complaints from our division of the number of times that we have called, but I'm adamant and I follow ministry guideline and regulation in which police need to be involved. And also too, it sets a precedence to many of our residents. Many of these critical incidences are separate incidences, so I haven't seen multiple, like one resident with more than 2 critical incidences. So the precedence of police, I think, is very important, and I will still continue. Number of residents need more than 2 PSWs to complete quality care, and that is a challenge. By doing that, what we're going to be doing is we're doing a pilot, we're doing consistent assignment, in which PSWs will have one specific, residents of 10 will have one specific PSW doing the care, which I think will be essential. I think I only have a few minutes, so some of the risk and challenges is the number of critical incidences of aggressive and abusive situations due to difficulties, which is our main focus at St. George. In 2 weeks, I had 2 Form 1s, and I've had 3 resident abuse critical incidences. So it takes a lot of the time of the staff. We do interprofessional meetings. I speak with a psychiatrist. I speak with a GMOT team. I contact the police. There's a lot going on when it comes to these incidences. So definitely homes need the support. I mentioned about our police services. That's the difficulty also. Also too, when a Form 1 is issued, the hospital has a tendency to discharge the resident back to the home within 45 hours. This too is a challenge. Starting this year, what I do is I actually contact myself, the physician, and I also too contact the hospital POAs and everyone and let them know the situation and that the home is going through a very high risk situation. So to me, the key is communication. The long wait for one-to-one funding from high intensity is also a challenge. Currently, we have one resident who is on a one-to-one funding for approximately 8 months now, doing well now, but it took a long time. And also, too, the challenge of having that one PSW per shift, also, too, very difficult when it comes to our staffing model. So the slides are here, so I think I'm going too long. But there's many risks and challenges, but is our current strategies. And what it is increasing staff engagement, planning to improve processes, and having staff part of the solution. Access to community relations police officers, so I'm working on that in our division, so I have a specific police officer to work with us when we have these issues and to be an advocate on behalf of the home. Building on internal behavioral resource teams, so education we're providing, we want to have our own within our home internal resource team instead of just the outside partnerships, but within our home itself. Utilizing of supplementary one-to-one funding during communications, referrals, decision-making, and intervention processes. Marketing of staff, we have a lot of student placements, and we've had a high population of student placements who have stayed and remained at St. George as employees. And a new culture shift. That's a major ordeal, knowing that this is the clientele we have, and trying to get the other type of clients in is a major challenge at St. George. But as a home, we manage, but again, too, if we have our support from our ministry, and so forth, our other external stakeholders, solutions can be made. Okay, thank you.